Hi everyone, my name is Brianna Sims, and today I will be presenting a project I did over the past summer, in my internship for my final nursing course. So, I did a research project on the differences in contamination rates between peripheral intravenous catheters, so regular IVs, versus what we call straight sticking, but it's called venipuncture. So it's just where you would insert a needle um, into a vein, collect the blood that you needed, and then you would take it out. It would not stay accessed in your vein. Okay, let's get started. So, a little bit of background. Um, I work in an ER, and I have later in the presentation our own records of the contamination rates, but it is a very common occurrence for all IVs in any place, especially ERs, because they are a place where IVs are used for almost every patient. So, very common, which is why I chose this as my topic of study. So, the primary reason behind these increased contamination rates is mainly the lack of adequate sterilization or sanitation to the skin prior to inserting a needle into the vein, meaning they didn't clean the skin well enough to make sure there is no bacteria or infection when you're inserting something inside somebody's body. When collecting these blood cultures, the bottles are relatively large in size. They are marked with how high they should be filled on each bottle, which should be 10 to 15 milliliters that will be collected per bottle. This just makes sure that there's enough to provide an accurate reading. So, two sets of blood cultures should be drawn in a 24-hour period. These cultures should be drawn usually from separate sites to get a also more accurate reading, but making sure that it's over a day because they're getting medications and different interventions that could possibly change the outcome of their cultures. The purpose of my study and why I find this is so important, other than being a common occurrence, is that people who have false positive contamination rates have increased trips to being at the hospital, obviously for treatment, increased admission stays. They have overuse of antibiotics that they didn't need to take originally if they didn't have any bacteria in their body, which the culture showed they did, being inaccurate. And then also decrease the risk of patient morbidity. So my main question here, which I kind of explained previously, is in the emergency department, how does the insertion of peripheral intravenous catheters, or IVs, and venipuncture affect the risk of blood culture contamination? All right, so here are my levels of evidence. I used 4 articles in my research study. My first being a level 1, which is the highest level of research you can get, it being a systematic review. So that was my first article. My second article was a level 2, being a randomized controlled trial. My third being a level 3, being a controlled trial without randomization, and then a level 4 was mine was a cohort study. So, my outcomes from all 4 of my research articles that I read, the outcomes were all the same. So, each article showed that there was an increase in false contamination rates or contamination rates with the insertion of IVs versus venipuncture. So, there was actually a decrease in contamination rates or the risk of infection using venipuncture or straight sticking above IVs. So here is my internal evidence. This comes from the specific hospital that I work at. These rates show specifically in the emergency department, but also throughout all floors of the hospital. As you can see, it dates back to 2023 going all the way to May 2024. So the first column to the right, besides the date, is the total number of blood cultures drawn. So this is not specific to the emergency department. They did not provide me with that information, but they did provide me with the total number from the whole hospital. Then the second column is the number of contaminated specimens in the emergency department specifically. So as you can see, the numbers fluctuate. And then moving to the third column is the contaminated specimens in inpatient areas. Now, it's very obvious that these numbers in this column are much, much lower, but you also have to take into consideration that these patients have usually started in the emergency department where we provide them with an IV. So the floors are completing a lot less IVs than we are here in the ED, which is why our numbers are so much higher. And then the final column is just the percentages of contamination rates throughout the entire hospital. So the bottom 6 bullet points are showing what the hospital has done to try and decrease these numbers from 2023 until May 2024. So beginning in April 2023, they changed the waste tube, which is if you are trying to draw a blood culture from an already established IV, you have to use a waste tube. Basically, it's just drawing your blood and then you get rid of it because that blood that's connected in the catheter or having access to outside of your body is not sterile, and to provide accurate readings, you need sterile blood. So, a different waste tube, and then allowing it to be cleaned or sanitized more effectively. Then also in April, 55 of 61 emergency department nurses and LPNs, as well as medics, completed a competency with the sepsis coordinator, with the best practice being reviewed along with the change in the waste tube and removal of the skin plug formed by the puncture of the needle. So these nurses are taking extra steps to understand the risk of infection and how to properly draw blood cultures. Then in January 2024, there was a plan put in place in the emergency department that the sepsis coordinator had to meet with all new emergency department nurses, LPNs, and medics to review the sepsis bundle and blood culture contamination or collection during the first week of orientation. So right when a new nurse gets a job at our emergency department, they must meet with the sepsis coordinator to learn how to correctly draw these blood culture tubes and the policies to follow to ensure that there is the least chance of infection or contamination rate. And then a second meeting is held during the last week of their orientation to review both again and answer any questions after maybe practicing this that they may have acquired in the time of orientation. Next will be monthly. Each person is made aware if they have a contaminated blood culture. So these nurses and medics are aware if they are making continuous mistakes. It's not that it's kind of unknown if who or each individual has had a contaminated blood culture. These nurses know, and if they hit 3 in a year, then their competency with the sepsis coordinator must be repeated. A trial is also being held at another university hospital with the blood diverting tube instead of a waste tube, which is kind of attached to the J-lube where you would pull blood. That way you're not hooking it up to anything. There's less risk for infection. All right. So in summary, basically just looking at my articles, so we saw that all articles showed an increase of blood culture contamination when using a peripheral IV, as well as all of them showed a decrease in blood culture contamination when using venipuncture compared to regular IVs. Article 1 sampled patients 18 years or younger. Article 4 contained only adult patients, as in Articles 2 and 3 did not disclose the age of their participants. As well as only Article 4 used chlorhexidine to prep the skin. This is the best way of cleansing the skin to decrease the risk of infection using this specific chemical. So after completing this whole research project, I came up with a few recommendations. So it's very apparent based on my research that it's important to use venipuncture when drawing blood cultures, as well as using 2 different sites when drawing 2 sets of blood cultures, which is almost all the time. Always make sure you're using chlorhexidine before drawing these blood cultures and wait for the antiseptic to completely dry on the skin. If the antiseptic is not completely dried on the skin, it has not fully sanitized the skin. There is still a risk for infection as there would be if you didn't clean it at all. Clean the tops of the bottles or the tubes of the blood culture tubes. In each kit for these blood cultures, they come with their own wipes, 1 per tube. So they should all have these wipes that are included in the kit to be used to clean the top to also decrease the risk of infection. Waiting at least 15 to 20 minutes before drawing another set of blood cultures if using the same site. Collect a minimum of 10 milliliters of blood in each collection tube, but really it should be probably around 15 for the most accurate results, and make sure we're collecting 2 sets of blood cultures in 24 hours. Some ethical issues I ran into is confirming the patient has given consent for an IV or venipuncture. Every patient usually gets an IV, but we are to make sure that they are giving consent to do this. Only attempt to stick the patient no more than twice per nurse and no more than 3 times before using an ultrasound guided machine, which just ensures that you will get the IV in the vein without having to poke them a million times. If the child is under 15, using distraction techniques, always ask the patient if they take anticoagulants, which could cause them to bleed more, and maintain strong communication between healthcare providers and the patient, as well as understanding the patient has the right to refuse any IV or venipuncture. My personal learning experience is to continue to complete all appropriate steps needed to draw these blood cultures, double check the tubes and patient labels before sending them to the lab, only attempting an IV or straight stick twice before having a more experienced healthcare provider attempt, and continue to practice, watch nurses/medics, and always ask questions to improve the skill of IVs and venipuncture. And here are my references. Thank you so much.